Okay, so now we're going to have a look at the cardiac cycle. So the cardiac cycle is all the events associated with blood flow through the heart during one complete heartbeat. So in basic terms, we have the right and left side of the heart. And the first bit that we're going to start with is atrial systole, when the atria contract. So the same thing's happening on both sides, remember, and then ventricular systole, so the ventricular contraction, and this is made of three main parts, as we'll get onto, and then diastole after that, so that's when everything relaxes and the ventricles refill, and then atrial systole happens again. So this is the main outline of it. Now there's actually 5 phases, so you'll see that there's 1, 2, 3, 4, 5, most of them, there's 3 phases in ventricular systole, and these 5 phases are firstly atrial systole, then isovolumetric contraction, ventricular ejection, isovolumetric relaxation, and then late diastole. So we can illustrate these changes using a pressure time graph. So we can have a look at all these 5 stages here. So this is atrial systole, stage 2, stage 3, 4, and 5, corresponding to these times here for all these graphs. And we'll go through them as we go through the stages. So firstly, we have atrial systole, and this involves, so this is the atria contracting and involves simultaneous contraction of the left and right atria. The last 20% of ventricular filling is accomplished, so most of the ventricles are actually filled, so 80% is filled by just relaxation and allowing the blood to flow through passively. But this atrial kick, or atrial systole, allows the last 20% of blood to flow in completely. Then the AV valves are forced open, and the atrial kick has a greater role in ventricular filling with increased heart rate, so if you're exercising, then this could be more than 20%, but usually it's just the last 20%. And we can have a look at this diagram here. So atrial systole on these diagrams is this portion, this first portion here. And we can see that ventricular volume is increasing, it's filling passively, and then here you might have that atrial kick, where the last 20% of the ventricles fill. Now the pressure in the aorta is going down because it's not really having any blood, so the aorta is a bit irrelevant here anyway. Whereas the pressure in the left atrium is slowly increasing, and then we have that kick, where we kick the blood, the last 20% of the blood, into the ventricles, and also the pressure in the ventricles is gradually increasing. Now after all the blood is filled into the ventricles from the atria, the mitral valve closes. So whenever we have 2 lines cross, that means a valve either opens or closes because the pressure of one area exceeds another. So here we have the pressure of the ventricles exceeding above the atria, and well, this is really on to the next bit, but the key thing here is that after atrial systole, the mitral valve closes. Well, the tricuspid does as well, so you have to remember it's on both sides. And then we have the flow at aorta root, which is a bit irrelevant now, but we'll come on to these later. And the electrocardiogram, I think that's the only relevant thing here. That's atrial depolarization, is represented by the P wave. That burst of electricity allows the atria to contract. So that's the first stage. Second stage is isovolumetric contraction. The spiral bands of the ventricular muscle contract. They squeeze the blood upwards. So these ventricles are contracting and squeezing blood upwards. They force the AV valves closed, but there's not enough pressure yet to open the semilunar valve, so this is a very short stage. The AV valves are closed, but there's not yet enough pressure to open the semilunar valves. So the blood has nowhere to go, and pressure increases very quickly with the ventricles staying at the same volume. So you can see this stage here. So the ventricles are full, and they're not losing any volume because it's isovolumetric. Whereas here, you can see that the left ventricle pressure is increasing very fast, and at the end of it, the aortic valve will open, but at the moment, no valves are open. And there's no flow through the aorta during isovolumetric contraction because all the volume is in the ventricles. And this lub here is the closing of the mitral valve in Phonocardiogram, and Electrocardiogram shows the QRS complex, which represents the depolarization of the ventricles, which cause the spiral bands of muscle to contract. The third stage is ventricular ejection. So ventricular pressure eventually exceeds the pressure in the arteries, the aorta and the pulmonary artery. The high pressure of the ventricular blood displaces the lower pressure blood that's already in the arteries, and this increases the arterial pressure because the arteries are distended and engorged with blood from the powerful contraction of the ventricles. So you can see this here. So after the isovolumetric contraction, you have the ventricular ejection. So the ventricular volume decreases dramatically, and the stroke volume represents the volume that's ejected from the heart with one heartbeat. So some is left at the end. It's not like the ventricles empty completely with every heartbeat, some is left. Stroke volume is around 70 to 80 millilitres, and the end diastolic volume is at the end of filling or relaxing, which is about 120, and end systolic volume is around 50 or 60. So after the pressure increase, the aortic valve opens, allows all the blood through. So you can see the flow at the aorta root is increasing dramatically through the aorta and the pulmonary arteries, and the pressure in the left ventricle is gradually decreasing, and nothing's really happening to the left atrium. That's relevant here, and the pressure in the aorta is increasing as well, obviously. And this aortic blood acceleration is sort of just like a differentiation of this curve, basically, showing the acceleration of blood, so very high acceleration, and then after that it slows down and decreases acceleration, decelerates. That's not relevant here. And then T represents the repolarization of the ventricles. We'll get on to more about that later. Now, number 4 is isovolumetric relaxation, so the ventricles begin to relax. There's a rapid decrease in the ventricular pressure because they're relaxing, so all the blood has just gone off to the rest of the body and there's nothing really happening here. And it's the last stage of ventricular systole, and as ventricular pressure decreases below aortic pressure again, so ventricular pressure decreases below the aortic pressure again, a small amount of blood actually flows backwards. So there's a brief rise in the arterial pressure, which is the dicrotic notch. So this dicrotic notch here is caused by a small amount of blood actually falling back or flowing backwards from the aorta. And the final third of the ventricular blood flows away against the pressure gradient. So you'll notice that the pressure gradient here is that the aorta's pressure is actually higher than the ventricular pressure, so it tends to squeeze blood backwards. But the only reason that the last third of blood is expelled and doesn't go backwards again, despite this pressure gradient, is because it has momentum. So let's have a look at this. So isovolumetric relaxation, the last third, well, that's not really a third, but you get it. So the last third of the ventricular blood is emptied. We have a dicrotic notch, so some blood flows backwards, but it eventually goes where it's supposed to. The mitral valve opens again at the end of this to allow blood to fill back into the ventricles. That's not yet, that's a bit later. There's less flow at the aorta, so the last third of blood flows through here, remember, and then this is caused by the closing of the semilunar valves, this dub here. And the last thing we have is late diastole, and then we go back to atrial systole. So late diastole is when both chambers are relaxed and the ventricles begin to fill passively again, so ventricular pressure will increase again before atrial systole and a new cycle begins. So this last portion here is when the ventricles begin to fill again, aorta, left atrium pressure starts increasing, so this comes back here, and then the ventricle pressure obviously starts increasing again as it fills. And then the cycle begins again. So another way of looking at this cycle is the cardiac pressure volume loop, which is only really looking at the left ventricle. We only really look at the left ventricle here, even though we should know that both sides are the same things happening on both sides. So this is sort of looking at the cardiac cycle in 3D, and we're plotting volume of the left ventricle against the pressure in the left ventricle. So if we start at A, where the mitral valve opens, so it's the beginning of late diastole, mitral valve opens, and then the volume increases with a little change in pressure. So the volume is increasing, but there's not really much change in pressure, because we've got relaxation and ventricular filling. So it's illustrating this part here. So the left ventricle is increasing in volume. Atrial systole increases the pressure a little bit, and then increases the volume of the ventricles. Now at B, the mitral valve closes, so we're at here now, and ventricular contraction begins. So we've got isovolumetric contraction. The pressure in the ventricles is increasing greatly, whereas the volume is not changing really. And this is at end diastolic volume, so when it's completely full, it's about 120 milliliters. Got isovolumetric contraction. Once the ventricular pressure exceeds the aortic pressure, so ventricular pressure exceeds the aortic pressure, got crossing over here, the aortic valves open, and then there's ejection. Ejection means that volume decreases dramatically. There's a rapid fall in ventricular volume, and the aortic valves open, whereas there is quite a big change in pressure as well. So the pressure increases as the volume decreases. The heart doesn't empty completely, remember, so it always has around 40 or 50 left, which is end systolic volume, milliliters. And then here the aortic valves close to prevent the backflow of blood that's been ejected. And there's isovolumetric relaxation, so no change in volume, but a very dramatic decrease in pressure. The heart relaxes, and there's a rapid fall in pressure without much volume change. Now, aortic stenosis, so this would be a normal cycle, as we've seen here, and stenosis would look something like this. So if we just look at this diagram for a minute, we've got a higher peak, so higher pressure, and less filling, so greater end systolic volume. Now, this is a disease condition where you have impairment of the left ventricular emptying, because there's high outflow resistance caused by decreased valve orifice area. This means that you have increased peak systolic ventricular pressure and increased cardiac afterload. So this means the force opposing the ventricular emptying, and you have decreased stroke volume as well. So stroke volume is the difference between end diastolic and end systolic volume, and you have increased end systolic volume and end diastolic volume, and this causes the heart to work much harder because it has to pump at higher pressure, which doesn't really do much in this case, and you increase your cardiac mass, so you get increased cardiac mass, and then you get cardiac failure. So cardiomyopathy was the word I was thinking of. So yeah, not a good condition to have. Now let's look at jugular venous pressure. So this is observed during atrial systole. You can sometimes observe, if you're having a person elevated at 30 degrees, you can sometimes observe a pulse at the jugular vein, although it's really difficult to do this in practice. I have tried. So theoretically you can, and it's observed during atrial systole because a large pulse increase indicates an increased right atrial pressure. Some blood flows back into the vena cava when the atria contract, so we're talking about this little bit here, the atrial kick, because there's no valves between the atria and the vena cava, the right atrium and the vena cava, so some blood is forced backwards. Although the veins do narrow upon contraction of the atria, and this retrograde movement is supposed to be able to be seen in a person lying at around 30% elevation, but it's, as I said, pretty hard to do so. And if you can see it when they're standing up, then that means they've got significant right atrial pressure increase, which is really not good. Now the phonocardiogram, so we saw what the phonocardiogram looks like in a normal person here. Got a lub and a dub sound. So this comes from auscultation, which is listening to the heart through the chest wall to assess function, which is an important part of clinical diagnosis of heart issues. So the lub, the first sound you hear is the AV valve closure, and the dub is the semilunar valve closure. Now you can hear additional sounds in abnormal conditions, and the third sound is called a gallop, so you can have gallops in the form of lub and dub. I imagine it would be pretty difficult to tell the difference, but I guess that's what you're trained to hear for as a doctor. So if you've got lub, dub, so two lubs, you have an AV valve problem because lubs are significant for AV valve closure. And if you have a lub, dub, which is two dubs, then you have a semilunar valve problem. Clicking, there's also other sounds. So clicking represents abnormal valve movement, and murmurs represent valvular incompetence, which is blood leaking through an incompletely closed valve. So you might hear like a whoosh, which signifies that the blood is not being completely emptied and some is leaking. Marfan syndrome is a collagen-related problem, so some symptoms are very tall and long-boned people, and this is a problem because collagen is a main component of the aortic arch, and this arch can be distended up to 12 centimeters in Marfan syndrome, which means that it's vulnerable to aneurysm, which is bursting or having a hole, and this is deadly because it causes massive blood loss and internal bleeding from the aorta, which is not good. People with the syndrome need to have constant screening to check their aorta isn't distended too much, and it can be treated by aortic reconstruction surgery or anticoagulants for blood. There's a lot of different ways to measure electrical activity in the body. One of them, as we've seen, is the ECG, the electrocardiogram. Other ways to measure it are the EMG, the electromyogram, EEG, electroencephalogram, and ERG, electroretinogram. So the electrocardiogram, I'll just go into a bit more detail about that. It involves recording small potentials, around 1 millivolts between locations in the skin, which reflect the underlying activity of the heart. Extracellular current flow across or around myocytes sets up small local potentials, and potential changes between different locations on the skin are detected because the spread of electrical current through underlying structures causes these potentials. So electrical events are coupled to cardiac cycle mechanical events, and so this is basically saying that by measuring the skin, electrical activity on the skin, we can infer what's happening to the heart, the electrical activity of the heart, and obviously it doesn't actually look like this, but it's more like a differentiated version, if you guess. So like the changes of the potentials. So the P wave, so the first wave, we just use this example, and it represents atrial depolarization. The electrical activity is spreading through the atria and causing it to contract. But remember that the electrocardiogram does not represent contraction or any mechanical forces, it's electrical activity purely. QRS complex represents ventricular depolarization, and T wave represents ventricular repolarization. Atrial repolarization is masked by the QRS complex. The RR interval, so from peak to peak, is an accurate reciprocal measure of heart rate. So if you do 1 over the distance from R to R, you'll get an accurate measure of the heart rate, or something proportional to the heart rate. Now the EMG, the electromyogram, is when you record a burst of activity when the muscles contract. So you could put 2 electrodes around 2 centimeters apart over someone's biceps, and when that contracts, you can record a burst of electrical activity. The EEG, or the electroencephalogram, is when you record potentials relating to neuronal activity by placing electrodes on the skull. You can look at brain function, which is important for psychological studies, for example, and ERG is an electroretinogram, which is recording neuronal activity resulting from light flashes, and you can detect this by electrodes placed on the eye. Long QT syndrome, so you can see a very long QT here, is caused by inherited channelopathies. So these are diseases which affect channels, ion channels, and that disrupts the electrical activity. So mutations in the myocardial sodium-potassium channels can be as a result of drug side effects or just mutations. And for example, a drug that was notorious for this was non-sedating antihistamine Seldane, which binds K+ repolarization channels, and this caused long QT syndrome in many patients that took it. And at least 8 deaths were attributed to Seldane before it was taken off the market, which highlights the importance of checking the side effects of drugs, really. So the intrinsic regulation of cardiac output, and we're going to talk about Starling's law. So Starling's law in general is this, so its force of contraction is the function of the length of the muscle fiber. So as you stretch the muscle fiber, the more you stretch it, the more hard it contracts to a certain point, you see. So Starling's law says that in the context of the heart, the contractility of the heart is dependent upon the degree to which the myocytes are stretched. Greater stretch equals greater force of contraction, and this was demonstrated by Otto Frank's isolated heart frog experiments, and Ernest Starling did his own experiments on isolated dog hearts to show this phenomenon in action. And obviously they had to do it independently of innervation or endocrine influences, so this is an intrinsic property of the cardiac muscle. What we mean by preload and afterload. So preload is the force of the blood going in through the vena cava, and afterload is the pressure or the resistance against the blood going out through the aorta. So Starling found 2 main things. Firstly, preload. Increasing preload increases the end diastolic volume, and that increases cardiac output. So if we just look at the green here, ignore the red first. So we have the end systolic volume and the end diastolic volume. So the blood would normally fill, it would expand the heart muscle, and then it would contract. So it would become a smaller volume, isovolumetric contraction at first, and then as the blood squeezes out, the volume would decrease to the end systolic volume. Now if we increase the preload, so the red is becoming relevant here, then we increase the amount of blood that's going in. So obviously the end diastolic volume, so the amount of blood that fills the heart will increase the volume. And then by increasing the end diastolic volume, we've increased the contractility by Starling's rule, which says that as the muscle is stretched more, it contracts harder with more force. And then now that increases cardiac output because more blood is being output from the heart with more force. So that's how it increased preload maintains or increases cardiac output. Now, increased afterload is a bit more complicated. So if we look at the green again, we've got normal conditions, end systolic volume and end diastolic volume. Now, if we increase afterload, then we will increase the resistance. We've got valves here. We increase the resistance of the blood, so the heart has to pump harder to get the blood out. So we're not changing the filling, we're only changing the force that's required to make the blood go out of the heart. Now, this increases the resistance and then decreases the stroke volume or cardiac output, but only temporarily. So obviously, because it has to work harder, it can't adapt immediately, so less volume will be pumped out and cardiac output would decrease very transiently. But then, because of this, you have a increased end systolic volume because of less emptying. So you're not emptying the heart as well as you should normally, and the end systolic volume will increase, which, as you know, stretches the heart muscle. This also increases end diastolic volume because, you know, if you're not emptying properly after the previous one, then the overall volume is going to be bigger, and then when more blood comes in, the same amount of blood as before, you're going to stretch it even further beyond the end diastolic volume, if that makes sense. And then, so increased afterload increases both end systolic volume and end diastolic volume, and now because the muscle is stretched so much, we have increased cardiac output. So it's a biphasic response. The cardiac output decreases first and then increases again, but this is not an increase like the increased preload caused. This is just a recovery of cardiac output. Now, there's a problem with this because it could cause the arterial pressure to rise too high, and it could cause cardiomyopathy, where the cardiac muscle has to work so hard to recover the cardiac output by this mechanism, that it enlarges, and that's really bad. So Anrep effect, again, is the autoregulatory effect where increased afterload causes myocardial contractility. So this is a separate mechanism to the Starling law, but it's a proposal of how this could work. So sustained myocardial stretch causes sodium ions to enter into the sarcolemma, the membrane of the muscle, and then decreases the sodium gradient. This stops the NCX, or the sodium-calcium exchanger, from working, which are in the sarcolemma. And then this causes calcium ions to accumulate in the sarcolemma. And calcium ions are uptaken by the SERCA, or the sarcoendoplasmic reticulum calcium ATPase pump. And this increases the calcium-induced calcium release in the sarcoplasmic reticulum. If you don't know what that is, then you might want to watch another video that I'm going to put out soon about muscle, which talks about cardiac muscle and stuff like this. But anyway, that's what happens, and then that increases the force of cardiac contraction, and the increased stroke volume and cardiac output maintains tissue perfusion. So yeah, this is important because if you preload increases, or if you have more blood or you have more resistance, you want to maintain your cardiac output to perfuse your tissues. And Starling's law and Anrep's law ensures that cardiac output remains regardless of preload or afterload. Increased afterload could cause arterial pressure to rise too high, and this requires extrinsic regulation to maintain homeostasis. We'll talk about that later, but firstly, just want to have a look at one theory which could explain the Starling mechanism. So why does the force of contraction increase as you stretch your muscle fiber more? And this could be explained, this is just a proposal, by the sliding filament theory. So stretch equals increase in tension of contraction because of these three reasons. So firstly, longer sarcomere causes filaments to buckle less. So these muscle filaments, if you watch my muscle video, you'll know the structure of muscle. You've got thin filaments interacting with thick filaments to create tension. And a longer sarcomere could mean that the filaments buckle less, which decreases the mechanical interference, and then more tension can be generated. And the second point is that as you increase the active force with increased cross bridges, you decrease the interfilament lattice spacing. And third is responsible from a protein called titin, or connectin, which is the largest protein known to date. It's about 3 to 4 megadaltons. It's huge, and it binds thick myofilaments to the Z lines and pulls them closer to thin myofilaments, which reduces lattice spacing, so that as you increase the length, then it doesn't, the fibers don't move too far apart. And number 4 could be increased sensitivity of contractile apparatus to calcium with stretch, but we don't know if that's true yet. It's just proposed. This graph illustrates the stretch tension relationship. So this is tension and length. So when you've got half the tension, half the length, these thick filaments are overlapping, everything's getting in the way. It's about 1.8 micrometers, so there's not really much tension being produced here. Everything's clashing, and cardiac is a bit steeper here than skeletal, but it's the same idea. And then as your muscle fiber stretches, you've got the optimal overlap is about 2.2 micrometers. So most tension can be produced here, about 100% of tension. And then as you increase the length even more beyond this, around 2 times the length, you've stretched the muscle fiber too much and it's not really overlapping properly, so the tension decreases. But the main idea is that in the middle, you have this optimal amount of tension. So the heart conduction system involves 5 main parts. We've got the SAN, the AVN, the AV bundle, or the bundle of His, the left and right bundle branches, and the Purkinje fibers. So we've got the SAN, which is the pacemaker. It determines the heart rate, and this conducts to the AVN. And then you have the AVN's in the septum. So the SAN is in the upper corner of the right atrium. And then the AVN conducts through the septum down to the Purkinje fibers, the bundle of His, the bundle of His first, and then the left and right bundle branches, and then the Purkinje fibers up the ventricles. So this can be regulated extrinsically from the parasympathetic and sympathetic autonomic nervous system divisions, and from the cardiovascular center in the medulla oblongata, and also endocrine influences such as adrenaline, which is catecholamine released from the adrenal medulla, and this binds to cardiac B1 receptors, adrenergic receptors, to increase both chronotropy and inotropy, which we will look at later, and this is called a sympathomimetic agent. So sympathetic and parasympathetic influences, so these are nervous influences. We've got the brain and spinal cord here. The cardiovascular center sends out the vagus, which is a parasympathetic nerve, to the SAN and AVN, and there's left and right vagus nerves. And this modulates, so these are only modulating factors. The heart beats by itself intrinsically, but these only change the rate to maintain homeostasis. So these vagus nerves release acetylcholine, and they bind to muscarinic receptors. This decreases heart rate or has a negative chronotropic effect. And then we have these green nerves, which are sympathetic cardiac nerves. These are coming from the thoracic spinal nerves, so T1 to T4, and then they form, so this is the sympathetic chain, and they form ganglia in the sympathetic chain, or they can synapse up and down the chain, and then they innervate the SAN, the AVN, and also the ventricular myocardium, which the vagus does not. So they have the capability of increasing heart rate, which is a positive chronotropic effect, increasing contractility, which is a positive inotropic effect as well, because they innervate the myocardium. Now, the accelerator nerves, or otherwise known as sympathetic cardiac nerves, release noradrenaline, and this noradrenaline attaches to B1 adrenergic receptors and increases heart rate and contractility where appropriate in the areas. And we can illustrate this as we look at the electrical activity. So if you watch my nerve and muscle video, then you'll know a bit more about this, but basically the action potentials are generated like this. So the pacemaker potential, SAN, it generates its own action potentials because it's very leaky and there's a decaying potential. So it starts off with a higher, more depolarized potential than normal nerve cells. So nerves would be like around -70, I guess. And then this starts off at -60, and it slowly, gradually depolarizes itself, it decays, and then causes an action potential when it reaches this threshold, which is about -20 something. So it depolarizes itself. Whereas if you give it sympathetic stimulation, then the key thing here is that it increases the slope. So compared to this, it increases the slope of the decaying potential, and that causes more action potentials to happen in a given time. Whereas if you vagus nerve it and you decrease the slope of the decaying potential, then you'll have less action potentials in a given time. So that's how it works, basically, how it modulates contraction and heart rate.